everybody, and thank you very much for joining us. Today, we're also going to have a recorded session. It's about a very common issue, oil fullness. And Dr. Brian Blakely from University of Manitoba is going to talk about this very common issue, how to go about the differential diagnosis and management of this everyday case. Now, again, next week we're gonna break for 2 days, and next week is gonna be we're building up a great program. I haven't had the final confirmations yet from the speakers, but I think you will be impressed, and hopefully you're gonna have a lot of live sessions. Um, I'll leave you with Dr. Blakely's talk.
If I can do this, let's see, share screen. Okay, good. Are you seeing the screen?
Great. Yes, absolutely.
Okay, good. Well, thank you very much for inviting me. This is very interesting to do a tutorial halfway around the world. This is approach to oral fullness. This is a presentation that I did with Maggie Aaron, who is my co-author. So I'm going to use some of her slides. It's always awkward to give a talk with someone else's slides. So part of this might seem a little bit disjointed. I hope there's time for questions, although I'm not sure how questions work in this environment. But anyways, it looks like fun, so we might as well proceed. Oral fullness, of course, is a common problem, and sometimes there's not an obvious reason for it. And that's the purpose of this talk. I found this symptom to be quite distressing and frustrating at times. First of all, we have nothing to disclose, no conflicts of interest. These are the learning objectives at the end that hopefully participants will be able to name some otologic as well as systemic pathologies that can manifest with oral fullness, and suggest the various diagnoses causing oral fullness. And please interrupt me if you can't hear or something is not clear or something.
I will tell you if we have a problem. Thank you, Brian.
Okay, good. Causes, when patients present with oral fullness, a nice way to think about this is there's the causes which have abnormal tympanic membranes and the causes that have normal tympanic membranes. And I think we're familiar with most of the abnormal tympanic membrane issues. It's like some atelectasis, early cholesteatoma, some fluid, serous otitis, and here's acute otitis media. I don't think we need to dwell on those too much. Those are common ENT presentations that we all are familiar with, I hope. Eustachian tube dysfunction sort of lies in the middle. You might have a normal tympanic membrane or you might not. But that's the way it goes. If you have an abnormal tympanic membrane, these are the common problems. Normal tympanic membrane is possibly one of these things. It's interesting, I think, that low frequency hearing loss can present with oral fullness. Of course, we know about Meniere's disease. The criteria are recently revised, and so that's what we do. If we don't understand a disease, we redefine it, and then we think we have some control. Superior canal dehiscence, patulous eustachian tubes, tensor tympani syndrome, which might be a bit controversial. Migraine is a definite cause of oral fullness and pressure. There are so many talks about migraine that I thought I might not deal with that too much, although it is an important area, but there's so many other talks on that I will bring it up, but I'm not going to discuss that in detail. And temporomandibular joint dysfunction, some people call it TMJ, some call it TMD, temporomandibular dysfunction, and there's a variety of other terms for it, but it's all the same thing. This is Maggie's checklist for evaluation of patients with oral fullness and a normal tympanic membrane. Do they have tinnitus, vertigo, autophony, recent weight loss, chronic nasal, sinonasal symptoms? I don't think sinus disease per se causes oral fullness, but often people who have sinus and nasal troubles also have eustachian tube dysfunction. Recent weight loss is important for patulous eustachian tubes, and the idea of if you do the Valsalva, can you open your eustachian tube and so forth. Tuning forks are fairly typical in physical exam. A nice addition for this particular symptom is blocked nose Valsalva, that is, you plug your nose and swallow, and standard audiometric palpation exam as well. So, oral fullness with a normal tympanic membrane. A question you might question for sinonasal complaints, and does the patient have troubles with barometric changes, diving, scuba diving, or airplanes, or so forth and so forth? And is there hearing loss, which might suggest Meniere's disease? I think this is a good idea to ask people who haven't really tested their symptoms with Valsalva to try it out and see if it works for them. And it's true, many people haven't really thought of this themselves, and we can demonstrate that. If a patient is able to make their tympanic membrane move when they block their nose and swallow, that's normal. However, just a quiet respiration, the eardrum should not move in and out. That would be patulous eustachian tubes. This is a good physical exam trick, I guess. People with oral fullness who can move their tympanic membrane with Valsalva are less involved than others who cannot. This is a little guideline, a questionnaire for possible eustachian tube dysfunction. Pressure in the ears, a pain in the ears, feeling that you're clogged, ear symptoms, cracking or popping, ringing, and a feeling that your hearing is muffled. These are standard questions. I'm not convinced that tinnitus is a good eustachian tube symptom, though. And these are the reminder again with normal and abnormal tympanic membranes. When you have a normal tympanic membrane, which is probably the most frustrating type of patient to encounter, because if there's an abnormal tympanic membrane, we know what to do, we know what the problem is. But when it's normal, it's a little more frustrating. There we go. One thing to question about is autophony, and this is the feeling that which patients find hard to describe, like you're hearing yourself talk, and of course we hear ourselves talk, but it's the feeling probably best described as the feeling like you're talking in a bucket, which does make some sense to patients, and you can use that to relate to describing if it's autophony. The two conditions that come to mind when this is a prominent feature of the presentation is superior canal dehiscence and patulous eustachian tube. Superior canal dehiscence is a very interesting disorder, fairly new, of course. It has pulsatile tinnitus and some subjective hypoacusis, and that's because of the sound energy which is lost and goes intracranially and does not reach the cochlea as it might. There's autophony and oculophony, which is the feeling that you can hear your eyes move. When I heard this, I thought this was crazy, but actually there are some people who do describe this, or a feeling that the sound is transmitted from your feet, from your ankles, all the way to your ears when you walk, which is quite interesting. And of course, they have a small conductive hearing loss, and oral fullness, which is the topic of this talk. Some in-office pearls are tuning forks, which we are familiar with, particularly perhaps the low-frequency one, which might be more revealing in superior canal dehiscence. The fistula test is shown here, and this I haven't found to be very common, but if you see it, it's interesting. This is a little video, which I hope comes through, of somebody who is being, the tragus is being pumped like this. This is Manohar Bance. There you can see the eyes rotating there with the fistula test, which is kind of, it's going to do the Siegel scope now. And I think you can see the eyes move. Can you see that? Is that visible?
Yes, absolutely.
That's Manahar Bance. Maggie Aaron got that. She worked with Manahar Bance for a while. Who's now in the UK. But anyways, so this is some, if you like acoustic reflexes, this might be what you might find. The right ear in this particular case has a small conductive hearing loss, so this would be where the dehiscence is. And you notice when it's IPSI, the threshold is lower, which is, this is the main line here, which is kind of interesting. The emittance or tympanogram is normal with superior canal dehiscence, which is not typical for most conductive hearing losses. And that's because the middle ear itself is okay. It's the disorder which passes sound into the intracranially, which is abnormal. So the emittance and tympanograms are normal. On the other hand, patulous eustachian tube is a little different. Of course, this allows air from the nasopharynx to go up into the middle ear, and you can hear your voice as well as you often can hear yourself breathing. The artists always draw the ear like this with a big tube, a giant pipe coming from the middle ear down to the nasopharynx, but in reality, the eustachian tube is just a very potential space usually. And I always like to point that out to patients. And so the idea, can you open it yourself, is relevant for some eustachian tube dysfunction, but for patulous eustachian tube, of course, it's open all the time. For me, the main physical finding is excursion of the eardrum with just passive respiration. You look in the ear as they breathe, and maybe even have them do a little sniff to push it. And it should not move. If you Valsalva, it would move. Of course, that's normal. And for patulous eustachian tube, the symptoms are allegedly improved with dependent head position. So the patient may notice if they bend over, put their head between their knees, or if they are lying down, that their symptoms are better. That would suggest patulous eustachian tube. It's sometimes hard to differentiate, is this superior canal dehiscence or patulous eustachian tubes? And these are a comparison. Both have autophony, although the patulous one is increased with exercise and decreased with mucosal swelling. But you might hear your voice in both ones. The eye movement issue is not present with patulous eustachian tubes, nor is pulsatile tinnitus usually. They may have a little bit of reduced hearing. The patulous eustachian tube, if the eardrum is damaged, I guess. Superior canal dehiscence often has a Tullio phenomenon, that is dizziness with loud sounds, but the patulous eustachian tube does not. And there may be a history of recent weight loss with the patulous eustachian tube, which is not prominent in superior canal dehiscence. So that's some ways on history of differentiating these two, which can appear kind of similar on the history. Options for patulous eustachian tube for treatment, weight gain, maybe, although I always am reluctant to suggest weight gain because it may not work, and then you've got a fat person that you've made angry and fat. Hydration, perhaps. People have tried various things, installation of boric acid and various powders. None of these work really well, though. I think there's various surgical approaches, and I've not had good luck with surgical treatment of patulous eustachian tubes. The problem is, how much do you inject, or what do you insert? And if you overdo it, then you have a closed eustachian tube. If you underdo it, you haven't treated them. So another question to ask is about clicking. Sometimes clicking is due to pulsatile tinnitus, but in this context, we're referring to clicking, which is not synchronous with the pulse. So what could that be? Two major disorders are temporomandibular joint, or perhaps middle ear muscle contraction, or tensor tympani contraction. Maybe stapedius, it's hard to know. Tensor tympani syndrome is somewhat controversial. It has these hypothesized mechanisms without awfully good evidence, I think. But one of the main symptoms can be oral fullness, as well as tinnitus and these other symptoms. And once again, the treatment for it is difficult. This is a a person who could voluntarily move their eardrum, which I'll just show this little video. I hope it comes through. Oh, there we go. Can you see that? Little eardrum moving a little bit. This is someone who could voluntarily move their eardrum by constricting muscles in their head. And this may be a marker for tensor tympani contraction. I always like to, I liken tensor tympani to palatal myoclonus. I think they're very closely related. The people with really marked palatal myoclonus pretty well always have clicking like tensor tympani people. Anyways, if the symptoms are intermittent, you can look for characteristic compliance and otoscopic changes, which may happen. There are some suggestions that palatal myoclonus would require an MRI, and that may be, but the numbers are small, and that may or may not be true. But a couple of those have not found anything. You can compare it with the other ear. If the symptoms are in one ear, that might be more convincing that it is tensor tympani related. Just a word about migraine. I think we're all aware of migraine, but there are some studies showing that oral fullness can be related to migraine. I think there are others, and these are the two that Maggie highlighted. 92%. That's quite a high number, and I think this is something we shouldn't forget. The teaching is that once you're a migraineur, you're always a migraineur, and that goes for dizziness and many of the other manifestations, and that's possible, I suppose. But there are many people who I see, and I'm sure you do too, who had migraine 20 years ago, and now they have oral fullness or some other symptom. I'm a little bit hesitant to say those people are that their disorder is necessarily due to migraine. So that's the first part. This is the sort of what I would call in the box, like standard ENT stuff for oral fullness. And that was Maggie's part of the talk. Mine comes next. This is one I thought I'd throw in. Perhaps balloon dilation of the eustachian tube might be a good treatment for some people with eustachian tube dysfunction and oral fullness. This is sort of a new intervention, of course, and I think we need more data on this, but it's an interesting development in our field. So that was Maggie's part. My part is more of the systemic illnesses that can cause oral fullness, which are not necessarily related strongly to ENT, but nevertheless have a lot of overlap with our specialty. These can be difficult to treat, and you may, we're surgeons, and we may not want to get involved in the treatment of these things, but even so, it's important to know what they are, I think. Again, no conflict of interest. And this is another objective. We'll be able to articulate a differential diagnosis for oral fullness. So these are some of the in-the-box things which we talked about before, which could cause oral fullness. These things that I was going to talk about next are these, which are outside the box, outside of our usual specialty, but it's good to be aware of. There are many other medical problems other than these, what I call functional myoneuropathies. This is actually a bad phrase because there isn't good evidence that there's any muscle damage, even though the muscles are sore. And so people argue about what we should call this group of disorders. But there are also some well-recognized disorders: arthritis, flu, polymyalgia rheumatica, statin-related myopathies. The statins for cholesterol can cause myopathy, and that can cause oral fullness. Rhabdomyolysis, Lyme disease, and perhaps idiopathic intracranial hypertension is a cause of oral fullness as well, which is a disorder I find hard to diagnose. Anyways, when the in-the-box questions and approach fails, then one might pay attention to the outside-the-box issues and ask about other things like facial pain, dental pain, throat pain. Do you have generalized muscle aches and pains and fatigue? Patients often don't tell the ENT doctor about this, so you have to ask specifically, do you have a lot of fatigue? Oh, yes, I do. And it can't be just a little bit of, oh, I'm a little bit tired, you know. It should be a fatigue that interferes with your life and prevents you from working fully or prevents your activities of daily life. And of course, headaches and migraine. Some of these functional disorders have bowel dysfunction, irritable bowel, and quite interestingly, some hypersensitivities. These are things like when you touch your ear, for example. I have a few patients who touch their ear, their pinna, that should not hurt, but they claim that that hurts, or they get funny tinglings and paresthesias. These are, of course, neuropathies or nerve dysfunctions. And I think it's valuable to think about the way the pain doctors classify pain. There is nociceptive pain, which means you have an infection or some pathological process which is irritating the sensors of pain, and that's normal and expected and helpful, actually. Then there's neuropathic pain, which means that the nervous system itself is not right. It may be a stroke, it may be some crush to the nerve, which is in the past, which is the inflammation is gone, but the nerve still doesn't function well. And I think that has value. In fact, the nociceptive pain, I think, is probably what causes a lot of oral fullness. It's good to ask about these other things too. Depression. These give you some idea of the psychological makeup of the patient. Are they using statins? Have they had rhabdomyolysis with funny colors in the urine? Fevers, bumps. We're looking for infectious illness, of course. There are four kind of types of neurons. The ones we're interested here are these ones, the free nerve endings. These are the ones that sense pain and are important for oral fullness as well. The categorization of primary sensory neurons is shown here. The A beta are large, well myelinated, and conduct quickly. They're particularly responsible for light touch and movement, though. The A deltas are pain sensors, particularly for brief, intense pains. However, for oral fullness and pressure, these type C fibers are probably the most important. They're unmyelinated and are responsive to long duration types of discomfort. But these nociceptors do not just sense pain, they also sense mechanical, thermal, and pressure, or oral pressure, for example, as well as pain. And so I think we can equate oral pressure or fullness as a nociceptive phenomenon, just like pain. So the pathways are very similar. However, it's in the thalamus that the unpleasant aspect is added to it that we interpret as pain or pressure. So one disorder which is very common and can contribute to oral fullness is fibromyalgia. And if you look for this, I'm sure you'll find this. If you're seeing patients, I'm sure you have some with this disorder. It is a very interesting disorder. When it was first described, people thought it was imaginary or psychogenic, which is typical. We don't believe things the first time we see them. But it's a very common disorder, featured with widespread pain all over the body and a lot of fatigue, like not just mild fatigue, but severe life-limiting fatigue are the main two symptoms. It's estimated that perhaps 3.5 or 3.4% of women and perhaps 0.5% of men have this. So if it's this common, you'll be seeing some of these people as, of course, they're coming to doctors. They have symptoms, there are a few features of this. Characteristically, all the blood tests are normal, unless you have some other problem, some other disorder, of course. But for just fibromyalgia, all the blood tests are normal, which is why people argue about should this be called a neuropathy. There's no evidence of muscles being abnormal. Is it a myopathy or a neuropathy? Initially, the American College of Rheumatology established some guidelines, and there's this widespread pain index, which basically means pain above and below the diaphragm. They indicate 18 spots in the body where there might be pain, and if you have a score greater than 7, symptom severity score greater than 5, then you have the diagnosis. That's nice. Except that nobody memorizes these, and in fact, others, since these were proposed, argue with them, and I think now the criteria are more, I don't want to say vague, but not quite so regimented. Generally, if you have this terrible fatigue and generalized muscle aches, that equals the diagnosis. However, you have to have these symptoms for 3 months and of course, not have some other disorder that explains the pain, polymyalgia rheumatica or something else like that. This is my own patients. I did a little survey for a year. 26 of them had met what I thought was good criteria for fibromyalgia. And of those people, these are the proportions that had otalgia, migraine, globus sensations, or no other symptoms. So it's quite a few of them as compared to the patients without fibromyalgia who had those symptoms. So I think fibromyalgia and the oral fullness and some of these other things which relate to anxiety tend to run together quite a lot. Another similar pain is myofascial pain syndrome. This is a bit different, but it's a pain disorder. It's more characterized by trigger points. And of course, we don't deal with the gluteus medius too much in ENT, but these trigger points can be within any muscles, and they are hyperirritable spots. And if you look for these, you'll find these. For us, it's often in the neck and the trapezius and the levator scapulae muscle, but you can often feel that little band, a little tight band of muscle, and kind of twang it like a guitar string, which is quite interesting. And it's usually localized. You may have 1 or 2 spots, but usually not like the fibromyalgia people who have it throughout the whole body. When these were first described, some people said they don't exist. However, they've actually been described histologically, and I think now the acceptance of these trigger points is more generalized. The pain in myofascial pain is often a deep, aching quality, often a burning or stinging sensation, and this is characteristic of neuropathic pain as opposed to nociceptive pain. However, the nociceptive and neuropathic pain don't always follow the rules that they're supposed to. Typically, myofascial pain occurs in one area, and these are some of the illustrations in various books. The dark red area here is where you might feel pain if you pressed on the white X's, which is quite interesting. So you press here in the trapezius, and you might feel shooting pain going up to around the head of the neck. Some rehab medicine doctors like to inject these things with steroids and local anesthetics, trigger point injections. However, for us, the myofascial pain syndrome has many ENT issues, which I put in red here, including headaches, cervical strain disorders, and a lot of people come in with muscle aches and pains and other things. TMJ, dizziness. This dizziness is usually a vague imbalance, intermittent, not constant, not spinning vertigo like Meniere's disease. It's quite common, actually. Neurocognitive issues, this is called brain fog, and so the sensation might be I just don't feel right, I feel foggy, my thinking's a little bit slow. And they do have some mild vestibular abnormalities on testing. Nobody understands these very well. There's a tendency to think that they're all one disorder, and maybe the manifestations are from a similar cause. I think we're familiar with temporomandibular joint troubles, which has different phrasing: temporomandibular joint, TM dysfunction, craniomyofascial pain. But the disorder is the same, often presenting with clicking and snapping. I think to make this diagnosis, you should have some supportive findings. I know some people look in the ears, they don't see anything, and they say, oh, you probably got TMJ. That's, I think, not adequate. You have to have some sign. A lot of people have a little snap or a little bit of cracking of their jaw and may not have significant TMJ. But it does often present with oral fullness. The temporalis and masseter muscles might be in spasm, and other muscles that insert into the base of skull can give rise to oral fullness. Sometimes the pain is sharp, but not always. Maybe worse at night and somewhat positional. So if you get people who say, gee, you know, I can't sleep on my right side because my jaw hurts, that's TMJ, really. Management options, other than analgesics and so forth, and the explanation, Dentists like to give splints, and that's okay. I think that I think they don't work as well as we'd like, and many people don't use them after applying them. I always like to suggest to people to try using a soft diet for a few days anyways, to see if that helps things, which often is successful. There used to be an approach using joint replacements. I think that has kind of fallen out of favor, though, probably for good reason. There were a lot of complications with that. So if we're going to contrast fibromyalgia and myofascial pain, I think this is one way of doing so. In fibromyalgia, the pain is generalized, whereas myofascial pain is localized. Fibromyalgia has tender points and tender muscles, but not really trigger points. This can be hard to differentiate sometimes. Fatigue is very prominent, of course, in fibromyalgia, but not so much in myofascial pain. The female predominance of fibromyalgia is not present in myofascial pain. And fibromyalgia tends to be chronic, difficult to treat. Myofascial pain actually, even if you do nothing, often improves or, let's say, fluctuates. I guess that's a better way. It might come back later, so forth. But both of these are very common disorders. However, yet another disorder is chronic fatigue syndrome. This is an interesting thing. This is obviously featured with a lot of fatigue, this time for 6 months, not the 3 months of fibromyalgia. And it is quite common, 2 to 26 per thousand, shown there. Women are a little more likely than men to have this, but it's the tremendous sex differentiation in fibromyalgia is not present in chronic fatigue. When this was first described, I think in the 70s, people thought, well, this is Epstein-Barr infection that is latent and persisting. That's been disproven. There are other viruses that may precipitate this, but very often there's no particular underlying cause. The leading theory about the cause is centrally mediated hypothalamic pituitary adrenal axis troubles. Okay, it makes sense. And if you see a lot of dizzy patients, there's a higher incidence of neurally mediated hypotension, which can cause some dizziness. I think more likely in young women actually who have low blood pressure. Some of the cardiologists and so forth get into tilt table testing for this, which might be good. It shows an impaired response to changes in position. This disorder was initially called, it's been called various things, systemic exertion intolerance disease, SEID, chronic fatigue syndrome, or myalgic encephalitis. But of course, there's no inflammation of the brain, so encephalitis is not appropriate. This just reflects the terminology that people have used over the years as this evolved. I think chronic fatigue syndrome is now the most recognized one. Here are the criteria, which are fairly well accepted, I think. It has to be new onset, not lifelong, ongoing, not the result of exertion, not substantially alleviated by rest. So people wake up, they may sleep and they wake up the next morning and they're still not refreshed by sleeping. And as indicated below here, after exercise or exertion, they have malaise and tiredness lasting more than 24 hours. And it should be significant. In other words, a little bit of fatigue is common, and we all have that from time to time, but there should be some effect on life, occupation, education, or whatever. However, for ENT, there's also some ENT symptoms, which I put in red here, which are relevant to us. Chronic fatigue syndrome is thought to have more sore throats and tender lymph nodes and some muscle pains here and there, and headaches, which are not typical for migraines. I always wonder when we do tonsillectomies if some of these things like chronic fatigue and neuropathic pain are causing the sore throats, and we do our tonsillectomies, and if they don't get better, maybe that's why. Maybe they had a disorder which was not infectious. And I think this is a thing to keep in mind for other ENT patients as well. However, the key point is that these three illnesses overlap a lot. There are differences, and there are different treatments to some extent, but in general, the treatment approach is very similar. which is perhaps NSAIDs, exercise, Tai Chi, a lot of psychological support. For all of them, the blood scans and blood work should be normal. When you're normal, in fact, I don't get a CT scan or any scan unless there's some other reason presenting. However, it's true that each symptom needs its own evaluation because there may be more than one thing going on. For all of these things, the history is crucial. And this is true of many disorders in medicine, Meniere's disease, and this is because we don't have good biopsy or good objective proof, a blood test or something that they have these disorders. Many patients need a lot of explanation, and for some people that's adequate, which is quite interesting. If they know what to expect, they often feel very reassured. So these are this is an approach for all of these three things: fibromyalgia, myofascial pain, and chronic fatigue. Sort of a stepped approach, which is what these steps are supposed to illustrate. Nothing works for everyone, so that it's reasonable to try different things in different people. As I say, not all of us would be interested in treating these things, but at least if we can explain it, it might be other physicians might be more interested in actual treatment. Explanation is often helpful and adequate for some people. As long as they know what it is and it's not a tumor or something, they're happy. Exercise, which can help, is usually stretching and gentle exercise, not aerobics and running a marathon and lifting 400 pounds. That actually makes things worse. But gentle stretching and Tai Chi, physiotherapy, people have great interest in this, and some are quite good at this. Whatever you can do to remove stress in your life helps. These are some of the medications. In theory, the pregabalin and gabapentin would work better because this is a neuropathic type of situation. In other words, it's the nerves that aren't working right, and these are the medicines which are thought to be more useful for that situation as opposed to NSAIDs. And yet, for the pain, some people like NSAIDs and it seems to work, so I can't get too upset with that. Possibly the first line of treatment for fibromyalgia might be tricyclic antidepressants, with the pregabalin, gabapentin as secondary. Not opioids, though, that would be a mistake usually. For myofascial pain, injection of trigger points is popular. And sometimes people use Botox and so forth. And alternative things, massage, Reiki, acupuncture. Actually, I took a course in acupuncture. I've been doing this for some people. It does work better for myofascial pain, I think, than others. There are differences in treatment, though, which suggest that these are perhaps not the same disorder. Myofascial pain tends to respond better to passive stretching and trigger point injections and even the acupuncture. Whereas fibromyalgia is very difficult to treat. And I always like to tell people that maybe 60% of people can get some improvement, but rarely do we get a total cure. And there's always a report here and there that favors steroids, but these need to be more, I think we need more evidence than that to be too convinced of that. Just a few comments about another syndrome which is quite rare, chronic regional pain syndrome. This used to be called reflex sympathetic dystrophy and causalgia. This is a very peculiar disorder where some minor trauma, maybe just a venipuncture or maybe just a minor injury to the elbow or hand. I had one patient last week who had a wrist, caused a lot of swelling and tremendous pain, yet without other systemic manifestations of inflammation. And it's thought to be a dysfunction of the sympathetic nervous system, some dysregulation of it. And so people try various things, gabapentin and tricyclic antidepressants, and it also is a very difficult thing to treat. People who go to the pain clinic often have this, are often seen with this in the pain clinic. And they may treat with steroids and try various things, but it's really very much empiric treatment, I think, difficult to manage. Anyways, Good. I wanted to allow about 20 minutes for questions, so I think we have that. I don't know if we can do questions with this group, but we got 95 participants. Wow.
Yeah. Well, we had the problem, Brian. The issue is that we had on this meeting we had a limit of 100. So I've been getting a lot of messages for people who've been trying to log on, and they couldn't. So we would have had a much larger audience if we had a bigger capacity. But thank you very much. This is great. Now, if somebody I muted everybody's microphone. So if you want to ask questions, you need to wave for me, and there's a button that you could wave, or you could send it to the chat, and then I will sort of manually unmute you and allow you to ask the question directly to Brian. Brian, you hear me, Brian?
Yes. Oh, yeah.
Okay, great. So, Brian, this, of course, this is a very, very common, very common problem in the ENT clinic. Can I ask you this? I mean, you went through a lot of possibilities and diagnoses, and my first question to you is, what like one or two things from the history you obtained that could really direct you in one direction or another? I mean, what is your number one or two or three questions that you feel are very, very important in guiding you further in terms of the treatment, in terms of the diagnosis?
Well, what I like to do is, ask other ear questions. Oh, I got oral fullness. Okay, how's your hearing? Do you have pain? And very often for many people, there are some other features that you can point this is your ears doing this. If all those are negative and your physical exam is negative, they have a normal tympanic membrane, then I think of those secondary things, the fibromyalgia, the muscle aches, and so forth, which is my approach. But it also depends. Each patient who comes in, you'll say, how's your hearing? Well, maybe not too bad. And it's never 100%, but that's my general approach. Focus on the ear first, see if there's any ear symptoms or findings, looking at the tympanic membrane. I like that approach of Maggie's, where there's the people with the abnormal tympanic membrane and the normal tympanic membrane. The abnormal ones, well, we kind of know there's fluid and there's glioblastoma and so forth. And the abnormal ones, then we think about these other things. And quite often, you'll be quite surprised about the people with fibromyalgia and migraine, but you have to ask about those things, because usually they come to an ENT doctor and they think, well, this doctor's not interested in my fibromyalgia, I won't tell them about that. And so they don't tell you. But if you ask, do you have fatigue? Do you have these other things? Sure, they'll tell you, and then you kind of have your diagnosis.
How about in terms of physical exam, beyond looking at the eardrum? Is there any one like maneuver or one thing that you do that are very informative or very contributing to the diagnosis?
Well, I think it depends on the situation. If it's oral fullness, I'm suspicious, and the history guides you. For example, I should back up. I don't think you need to do all tests and all questions on all patients. I think the history should guide you. For example, if you're questioning Patch's eustachian tubes versus canal dehiscence, have the patient bend over, and they may have already done this, and they may know it makes their symptoms better. That's the way I like to approach it. I don't like a battery approach where you ask all these questions, do all these tests on all patients.
So thank you very much for joining us this afternoon. Next week, we're going to have a lot of live sessions, and I think you'll enjoy it. We've done a lot of work for next week. So keep up with on the app and on the website, and I'll see you on Sunday. Thank you.